You are currently the only person in this conference.
Hi, this is Yuko, and welcome to lecture number 6. All right, you guys are already 2/3 of the way done. My goodness. So let's get going on neurodevelopment and the psychostimulants. Maybe not. All right, so here's your lecture objectives. So neurodevelopmental disorders are not as easily diagnosed in children. Only because they're still developing. They may not have the full capacity to be able to verbalize what it is they may be thinking and feeling. Whereupon with adults, of course, it's much easier. Children also lack abstract cognitive abilities and verbal skills. They are constantly changing and developing. So they have the similar problems that we see in adults, such as the mood, the anxiety, eating disorders, and oftentimes it may be diagnosed in infancy or childhood, which can be real difficult because then it's going to be predicated mostly on what the parents report, but it also can be diagnosed in adolescence. So there's a concept called resiliency, and what it says is that children and adolescents who have a higher degree of resiliency do better in life because they're better at adapting to things. They have better than average intellectual skills and oftentimes less vulnerable to stress. We know that each one of us is born with a certain level of resiliency. There are some who are just tough as nails, and there are some who are very, very fragile. So the resilient child or adolescent has a temperament that is more adaptable. They have a deeper ability to form nurturing relationships with other adults when there's no parent available. They can use problem-solving skills. They have social intelligence, and they're able to compartmentalize and remove themselves for any type of chaos in the family. So the theories are genetic factors, that it is passed down through the family, and also it may be the child's temperament, that resiliency. It may be biochemical. Is there a dopamine problem, a serotonin or epinephrine problem? Their environment too, also, you have heard that nurture versus nature type of thing. Children with mental illnesses oftentimes meet the criteria for more than one diagnostic category, such as ADHD, and oftentimes we know that 60-90% of those individuals also have juvenile onset bipolar disorder. So attention deficit hyperactivity disorder, in my personal opinion, I feel that it's probably one of the most misdiagnosed disorders that there is in children. It's difficult to diagnose before the age of 4, but the problem is that the child has problems being able to adjust to school. They can't control their behavior. So I'm going to show you a list of behaviors that they manifest: inattentiveness, hyperactivity, impulsivity, flight of ideas, being labile, going from one extreme in a mood to another, and anxiety. Now, I want you to tell me which one of these symptoms does not sound like the typical child. All right. Heck, I even know some adults who this describes to a T. So we know for ADHD, no known cause exists. We know that there are predisposing factors such as history, could have been prenatal exposure to toxins, low birth weight. We do know with children that the brain scans reveal that there is an underdeveloped and inactive frontal lobe. Make sure you remember that. So what can we give them? We can give them medications. Methylphenidate is an oldie but goodie. It's been around for a very, very long time. In fact, there was some concern several years ago that long-term use of it may cause permanent, irreversible learning disabilities. It also comes as a transdermal patch, also known as Daytrana. Concerta is the extended release of the methylphenidate. Adderall is a combination of dextromethamphetamine and amphetamine, and it also helps to calm. It does come in an extended release form. So 30% of children are considered to be inattentive. All right. We can give them medications, clonidine, very powerful antihypertensive, because a lot of them have a problem sleeping. The problem is because of the antihypertensive action of the medication, you've got to watch them for postural hypotension. How many children wake up, sit up in their bed, give themselves a couple of minutes to acclimate, then dangle their feet over the side of the bed and wait for a couple of minutes before they stand up? They don't, right? They go from lying to upright within a matter of like 2 seconds. When that happens, their blood pressure tanks. And then what's going to happen is that the child is going to lose consciousness. So you need to teach them to move in a slower manner to give themselves times to allow their blood pressure to equalize. Well, good luck with doing that. It does improve children's symptoms in age 6 to 17-year range. Guanfacine also helps to treat with aggression and any type of insomnia. You can give them TCAs or bupropion hydrochloride to also help with their moods and also with their behaviors. So here's what you need to teach the parents. Make sure you remember this slide. To reduce the adverse effect of anorexia, that's a side effect of the medication, make sure that it's given after meals, that is breakfast and lunch. To prevent insomnia, the medication should never be given any closer to 6 hours before bedtime. Administer sustained release forms in the morning after breakfast. The child should be weighed regularly to make sure that he's not losing any type of weight. All right. Inform the parents to not give their children over-the-counter cold and hay fever preparations, especially things with dextromethorphan. It's because they contain a simple mimetic agent that compounds with the ADHD med and causes a toxic effect. And that's why I don't know if you remember, but a few years ago they pulled all of the cold and hay fever preparations off the shelves for children. Okay, so we can give the child psychostimulants. The reason they work is because of that underground frontal lobe. So we can give them dextroamphetamine, which is Adderall, a tamoxifen, which is Strattera, methylphenidate, which is Ritalin. Dexedrine was an oldie but goodie diet medication. Quilivant is methylphenidate. Modafinil, also known as Provigil, Pro for Vigil, Vigilance. Modafinil oftentimes too is used with Parkinson's patients because they get early afternoon somnolence or sleepiness, so they will give them the modafinil to help wake them up. So we talked about the guanfacine, the lisdexamphetamine, and then the Focalin, which is dexamethylphenidate. Now, I don't like giving kids these medications because of the amphetamine base, because unfortunately they can become addicted to them. I'm a big pro for giving children what's called a drug holiday. That is where you pull them off of the medication on Friday and let them go through the weekend without it, and then give it to them again on Monday, or during the summer. You take them off the medication during the summer, allow all the metabolites to wash out of the system, because in the summertime, right, they can go out and run around and act like wild banshees and work off some of that energy. And then when school reconvenes, and you start them back on the medication. When you do a drug holiday, oftentimes, because you've stopped the medication, the metabolites have had time to wash out of the body. You restart them on the medication. You can usually restart them at a lower dose, and it will be more effective. Okay, and that's it for this presentation. Hold on while I change slides. All right, so let's take a look at anger, aggression, and violence. I'm pretty sure y'all know what somebody who's angry looks like, what somebody who's being aggressive looks like, and most certainly what somebody who's being violent looks like. Here are your objectives. So anger is an emotional response. It's normal. It's not always logical, okay? Whereupon aggression can be self-protective because maybe you've got to protect yourself or your loved ones, all right? And it can be the act of initiating hostilities, all right? All right, so we do know that neurotransmitters such as serotonin are decreased and increased dopamine and norepinephrine are present, all right? There may be structural damage to the limbic system as well, and there may be damage to the frontal or temporal lobes. So the theories are that they never developed impulse control, that they had inconsistent responses to their behaviors, or they were personally rejected, either by parents or loved ones. All right. Now, violence is totally different. It does have the intention of doing harm to either a specific group or to a person. It's unjust, it's unwarranted, and it's an unlawful display of force. Of course, then there's bullying. And lateral bullying is where it's done by a person of equal status. Where do we experience bullying the most? In the nursing profession. In fact, there's an old adage that says that nurses eat their young, which is quite a sad thing to hear. So we know that it's almost every nurse, everybody who's worked in a hospital has been either experienced it personally or witnessed some form of bullying take place. Back when I was a young nurse, it was always the physicians who bullied the nurses, but nowadays it's more the nurses bullying each other as well. So, behaviors, unwanted or invalid criticism, taking credit for somebody else's work, making derogatory comments about the staff, gossiping or spreading rumors, sarcasm, being condescending, blaming somebody without factual justification, allocating unrealistic workloads. Okay. So foul language, broken confidences. So, the old adage too in a hospital is if you don't want it spread around, then don't tell anybody anything that's personal. All right. And I'm telling you that's probably one of the best pieces of advice that you will ever hear. So what makes somebody more susceptible to being bullied? Being a new grad or a new hire, okay? Getting a promotion that other people don't think you deserve, working under conditions of severe understaffing. And for those of you who work in a hospital, how many of you can tell me that you've ever worked in the ideal situation where you have had enough staff or an overabundance of staff, right? Usually we work in an understaffed situation. All right, so where is violence most likely to take place in a hospital? I can tell you biggest place is going to be waiting rooms. And the reason for that is because people are there, they're ill, they're anxious, right? They're not feeling well, it's crowded, it's noisy, there's long waits, and there's frustration, and they get angry. The next highest place is going to be the emergency department because there's a lot of emotion flowing through there. All right. Then, of course, the psychiatric units, and then, of course, the geriatric units. So, what contributes? Individuals with PTSD, individuals who are substance abusing, people who are anxious, psychotic, personality disorders, of course, because it's done for the attention, people who are depressed, right? We know that the hypothalamus and limbic system contribute to emotions as well. So here's some questions you should be asking the client. Have you ever thought of harming someone else? Have you ever seriously injured another person? Whenever I admit a patient, this is one of the main things I ask them. Have you ever seriously injured another person? Because that gives me a red flag, especially if he broke the nose on a nurse at another facility, right? Then I'm going to put it on high alert because we need to keep an eye out on because he has the history of aggression. So try to get as much information as you can. If the patient won't do it, then go to family members or friends. All right. Um, so signs and symptoms. The patient may become angry, may be irritable. They may start to pace, be restless, slamming doors. They may have a clenched jaw or fist, or you can look at their face and see that they're really, really getting rigid. Or they may become verbally abusive and be calling people names in a loud voice and so forth. All right. Intense eye contact or complete avoidance. The one that really scares me is the person who is silent and just sits there and is seething, and you can't tell because they may be sitting with their back to staff, but they're they're thinking about things. Anybody who's suspicious or paranoid as well. Anyone who's intoxicated, all right? And anyone who has possession of a weapon. All right, so what can contribute to this on the unit, the milieu? It can be loud, it can be overcrowded. There always seems to be a specific group of patients that likes to pick on other patients, and I don't know why that is. And they kind of move around like a gang. A lot of times what they will do is they will incite violence from patient to patient, and they enjoy that. They like to sit back and watch it occur. So you've got to really watch the dynamics going on the unit. You may have staff that's really controlling, or staff may be very inexperienced. People aren't setting limits. They're letting certain patients get away with something that they won't let other patients get away with. So everybody has to be on the same page. All right, so what do? Make sure you assess for safety, not only of the patient, but for us as well. Be calm, be in control. If somebody is yelling, don't try to yell over them. Drop your voice. Speak softly, don't be judgmental. Be genuine and show empathy and concern. Set clear, consistent, and enforceable limits. And if the patient says, this is what I want, say, I hear that this is what you want, but unfortunately, I am not able to get that for you right now, but I will get that for you as soon as I possibly can. All right? So again, don't tower over them or stare at them. Use clarification, such as, I don't think I quite understood what you said. Let me say what I think you said. Is this right? Okay, use clear, simple, short sentences. Allow them time to be able to talk. All right, try to get them in an environment that's reduced in stimuli. All right, you can offer diversional therapy, like, why don't we go out on the patio and you can do some push-ups, or you can do some exercise, or go out on the patio and listen to some music and you can dance. All right? All right, so we can put them into therapy so we can help them to be able to learn about their aggression. We can do cognitive behavioral therapy based on anger management. We can give them medications, the atypicals, right? The typicals, such as haloperidol and the B52. All right, benzos, short acting. We can give them beta blockers. Beta blockers are really helpful to decrease aggression in schizophrenia. But because they're beta blockers, we've got to watch for postural hypotension and heart rate. All right, so we can use carbamazepine, which is also known as Tegretol. The problem that we have with carbamazepine is long-term use can lead to agranulocytosis. All right. Anticonvulsants are really good to reduce rage reactions, but remember that many of the anticonvulsants you have to do labs on to make sure that the patient is not getting toxic. Lithium, too, is also very good for mood disorders. But again, you also need to get labs to make sure that the patient's not getting toxic. Remember that lithium, you cannot dispense ibuprofen or Motrin along with it, and you have to monitor their sodium along with the lithium level to make sure they are hyponatremic, because lithium binds with the sodium to move through the body, and you don't want them to get toxic. Remember also that you do not want to use lithium in anybody who has to have a sodium-restricted diet. All right? And that's it. And let's talk about restraints. All right, so restraint and seclusion. Here's your objectives. Pre-assaultive stage, stages of violence. This is where it's really effective to be able to use de-escalation. You can use diversional therapy, have them go out and exercise, sit down and talk, do some sort of large muscle activity to help work off that anger and that anxiety. In the assaultive stage, pre-assaultive stage, this is where oral medications are going to be most effective. So you can offer them things like lorazepam to help calm them down. In the assaultive stage, you're going to have to give medication, and unfortunately, it's probably going to have to be IM. I always take both, and I give them a choice as to whether or not they want to take it orally or whether or not they want me to give them the IM. Post-assaultive stage, they've done their thing, they've been put in restraints, and now we've released them. Make sure that you do a debriefing not only with the patient, but also with the staff and also with the other patients on the unit. If we were in the clinical situation and there had to be a hands-on intervention, students may not at any time intervene or assist with anything hands-on. So, early aggression, we can do planned activities, one-to-ones. We can offer oral B52. We can give them medications to help to calm them down. When they're starting to trigger, don't be threatening. Approach them in a calm manner. All right, suggest they go to a quieter place. Again, you can order them medications. You can do diversional therapy. Speak to them in short, simple statements. When they're escalating, one person's going to have to take control, and that's going to be the individual that has the best rapport. All right, speak to them in a calm but direct voice. Have another nurse call the doctor and obtain an IM med order. Direct the patient to the timeout in the quiet room. Communicate that aggressive behavior is not acceptable. Offer IM meds. And if you need to, you do what's called a show of force. That's where you get as many people as possible, and one person approaches the patient, but the people stand behind that one person. And it isn't used as a threat. It's to show the patient that if we need to intervene for his safety, we have enough people to be able to do that with his safety in mind. When they start to become aggressive, then that's when you're going to have to take charge of the situation. You're going to have to put them into restraints, okay? So always restrain the patient on their back, never on their stomach. You should have one arm up, one arm at their side, and you should restrain both legs. You have to release the restraints. And when you do that, never release the same two restraints at the same time, because you're either going to get kicked or you're going to get punched. But release like the left leg and the right arm at the same time. All right, you need 4 to 6 members who are trained to put the restraints on for safety. All right, and then assure the patient that this is for their safety. And once they have calmed and regained control, they will be released, and the client goes on automatic one-to-one. Okay, so when they're recovering, now they have calmed down, we've been able to let them up. Find out what set them off, and what can we do next time this happens, okay, to prevent this from happening. Encourage them to sleep, because oftentimes they've been medicated, so the medication is making them sleepy, all right? Document and assess any injuries, not only to staff, but also to the patient. debrief with everyone, encourage the other patients to talk about their feelings, because it's pretty scary to see somebody who's being taken into a physical hold. All right, don't discuss the patient's aggression or anything with the other patients. All right, so let's look at some orders. Okay, so I will let you read this order. This tells you what behaviors cause the patient to go in restraint, what behaviors are going to cause the patient to come out of restraint, that we used a what happened here? That we used a therapeutic hold using what's called CPI, non-crisis prevention intervention techniques. Now over at Banner, they use AVADE, A-V-A-D-E. Okay, but you want to say that you use the techniques that you were trained to do to prevent the client from further injuring himself. All right? The charge nurse may act as a licensed independent practitioner and perform a face-to-face assessment of the client's medical status in 1 hour, because by law, a physician has to do that. All right? And here's another way to write an emergency med order. All right? Notice the word chemical restraint, so it is a one-time order. And you have to have the order to be able to put the patient in a physical hold. And that's it. Thank you. If you have any questions, let me know.